Good evening. Welcome to this evening's webinar, and thank you for joining us on this lovely night. Tonight, our host is Dr. James Galloway, and he'll be joined by Dr. Jo Ledingham, Dr. Mark Yates, and the chair of the NEIAA patient panel, Paul Amlani-Hatcher. Please note that this webinar is being recorded and will be made available on the BSR website. For now, I will hand you over to James.
Thank you very much and good evening. And we're going to give a few minutes for people to log in. I know that we've got a few people who will be joining dead on 7. Can I introduce while we're just waiting for people to join? I think I'm James Galloway. Some people have met me. I think people also very familiar. I was about to say to my right, but it's sort of in the Ethernet. Dr. Jo Ledingham. Jo, hello.
Hi, welcome everybody.
And from my screen, who is below me, Dr. Mark Yates, a postdoctoral fellow at King's, who has been invaluable on the audit. Mark?
Hi, everyone.
And I think, Mark, can I ask you to hide your video?
Sure.
And we'll just... Paul, do you want to join us? This is our moment of truth on the technological advances that we...
Hello, yeah, hello,
Paul,
yeah, hi, yeah, hi everybody. And
So Paul has led our patient panel with the national audit, and everyone is going to be joining us to talk. Paul, thank you very much as well for joining us this evening from home.
you're welcome. Yeah, it's a hot day, and but it's going to be even hotter tomorrow. So I think.
Yes, I've seen that. Yes, I think everyone should be sent home tomorrow.
Or what?
That sounds a good plan.
Jo, have you got air conditioning in Portsmouth?
We have in the hospital, yes. Yeah, it's actually quite civilized in the hospital. But yeah, we went through we were in porter cabins for a while where we had our PFI built, and we were in porter cabins without good ventilation and without air conditioning, and we were well above recommended temperature levels. So I very much appreciate the air conditioning in the new building. So we do benefit from that, and it actually does make a huge difference.
It's not in the organisational form about air conditioning provision, is it? We haven't captured that in the audit.
We haven't. Maybe we should.
Paul, I'm guessing you're working from home tomorrow without air conditioning.
Yes, yeah. Funny, isn't it, that the offices actually are probably the best place to be when it's super hot. But I don't know how happy people are to go into their offices at the moment. Maybe the car, if that's an option sometimes.
An air-conditioned
car.
Not
good for the environment, but obviously it's not every day.
Right. I upgraded my chair this year to a very comfortable luxury chair, which I think was mostly just it's a very nice chair. They're on sale at the moment from John Lewis, but it's like a fake leather chair, and I 33 degrees in this chair is not doable. You just stick to it. I'm regretting the choice. Right, it's 4 minutes past 7. Paul, can I if I ask Paul to minimise, Paul will be back with you in a minute. Thank you very much. And Jo, thank you very much for joining us. And Mark, hello again. So the purpose of this webinar is to talk a bit about the National Audit Supplementary Report. I hope some of you have seen it. So the National Audit is still running. We'll come back to that a bit later. But one thing that we did in the first year was to publish an annual report. But you will have noticed, if you read that, we didn't report on the 12-month data. And that was, of course, because at the point of 1 year in, only a few people will have met that 12-month time point. So we wanted to publish an interim supplementary report which would capture the 12-month outcomes. And that's now published. And so this evening, first of all, Mark is going to give us a talk through some of the data. Then Paul is going to give us a patient perspective on that report. and then Jo and I will come back and talk a bit about next steps and where the audit is going from here following that COVID thing. I wonder, before we start though, Jo, obviously the audit has sort of had huge impacts from COVID, but just in terms of, I don't know if you want to say a few words at the beginning about the supplementary report and its sort of background and context.
Yeah, so the supplementary report was really produced primarily to try and provide updated information on the annual data, but also on the data linkages, looking at some other outcomes, and Mark's about to give us a summary of that information. But I hope people have found it actually a useful document. The data capture was ahead of COVID kicking in, so everything that's reported really reflects what was happening pre-COVID. We're obviously going to get some different data, I suspect, post-COVID, and we totally accept that, and we know that units will be up against it quite a lot as we head back into our clinical work. But from my perspective, I'm really reassured and pleased with a lot of the data that we're capturing. We're getting reliable data and good data quality. The sort of data that we have seen, in particular looking at outcomes, is showing over half our patients are hitting remission levels on their DAS at 12 months. Totally accept that's a snapshot and there may be sort of variations there, but I think that's a good outcome. And also we are managing to capture that data, which I think is a great accolade to our rheumatology community. So for those of you out there, and pass it on, our thanks for all that data capture. But I hope you find this additional information useful, and it will be incorporated into future annual reports. But this was an extra report really because we had data that we couldn't put into the first annual report, but we desperately wanted to get into the public domain and make available to everyone as soon as possible. So that's the sort of background on that really.
Jo, I thank you very much. I think I'm going to come back to you, Jo, with lots of questions, such as what's happening to outlier reporting and so forth in a bit. But can we now, I'm going to turn my video off and Jo will turn her video off, and we're going to hand over to you, Mark, and allow you to talk us through some of the data.
So thanks for the introduction, James, and thanks to Jo for introducing the report as well. So as James mentioned, I'm a research fellow at King's, work alongside James, and I've been on the methodology team for NEIAA since its launch a year and a half ago now. So the supplementary report, so just a bit of an update on the audit and the supplementary report as well. So we paused data collection in March as a result of the COVID-19 pandemic, and we're currently awaiting approval to restart our data collection, and Jo's got a bit of an update on that, which we'll talk about a bit later on. Earlier on this year, we published this supplementary report, which, as Jo mentioned, brought together some of the 12 months outcome data, as well as some of our data linkages to mortality data and admissions data and joint replacements data as well. And in terms of the future horizons for future reports, the next annual report is due in the autumn. We're just finishing our kind of first drafts of that, so watch this space for some more interesting results from NEIAA. So in terms of the supplementary report, so what we're including, as I've already mentioned, is information from the 12-month follow-up, in particular looking at the annual review, and the amount of targeted therapy prescribing, and also the patient-reported outcomes. And then, as I mentioned, these points from external linkages to NHS digital data. So what are the headlines? So the first headline really is that 43% of our patients receive an annual review, and only 15% are commenced on targeted therapy by 1 year of follow-up. And 54% of patients are in remission at 1 year follow-up. And what we see over the first year from diagnosis to 12 months follow-up is that the burden and impact of EIA reduces on patients during that time, which is what you'd expect. And we've noticed that there's substantial regional variation in unplanned admissions. So just to dive in a bit deeper on those points. So in terms of annual review, you can see that there's quite a lot of variation by region. So you can see that the worst performance by region in the top graph on the right here is London, with about 15% of patients having an annual review, and the top performer being the East Midlands with 68%. So quite a broad range there. And just to dive in a bit deeper on what these patients are actually receiving, so of the patients who where it was indicated that they had received an annual review, this is the spread of things that different regions were achieving. And you can see there's quite a lot of variation again there across the regions. And crucially, one point to flag here is that we weren't measuring or assessing where the review was taking place. So it was acceptable if the annual review was done within primary care, as long as a rheumatologist was aware that it was taking place. So it didn't mean that every patient had to have a FRAX score done, for example, if the GP had already done it. So now moving on to targeted therapy. So again, we can see there's quite broad regional variation here, with the range ranging from about 10 to 20%, lowest in Yorkshire and Humber and highest in east of England. With that's targeted therapy by 1 year of follow-up. And now this is probably the most interesting slide, I think, is the burden of EIA. So this is looking in particular at our patient-reported outcomes. And if I just take you around these graphs, so in the top left corner here, we've got disease impact, and these are the mean MSK-HQ scores at baseline, 3 months and 12 months, and a higher number equals a lower impact. So we can see that the impact of EIA is reducing with longer follow-up, which is good news, and that's also reflected in the HAQ score, which is the graph below that, which is more of an assessment of functional ability or disability. And then in the top right, we have work impact. So what this graph represents is the grey bars represent absenteeism, so how absent people are from work, and the blue bars are presenteeism, so essentially to what degree is their productivity affected when they're at work. And then the orange bars are a combination of the two. So as we can see, the impact on work is reducing with longer follow-up. And then in the bottom right, we have mental health. So these are patients that were screened as likely to have a depression or anxiety issue on our screening questionnaire from the patient-reported outcomes. And as you can see, the numbers come down with further follow-up, but quite strikingly, over a quarter of patients still screened for having a mental health issue related to depression or anxiety at 12 months follow-up, which is really quite a striking finding. Now onto the linked data. So during year 1 of NEIAA, we found 343 patients had unplanned admissions, which equates to around 159 per 1,000 patient years. Again, quite marked regional variation with 112 per 1,000 patient years in the southeast, compared to 207 in the East Midlands. And then moving on to joint replacements and mortality. So these are quite low numbers. So 19 people had joint replacements in year 1, and there were 42 deaths. So the numbers are so low here, it's not really appropriate to present regional variation with such low numbers. So that's kind of a general review of the supplementary report. So I think back to James now to open up for further questions, I think initially with Paul.
Yeah, Mark, thank you very much. And that was a very nice run through of the data. There's a huge wealth of data that isn't in here. There is obviously departmental level, so provider level information is available to download on the website. We don't publish, and I'm aware someone's asked, do we publish consultant level reporting? We don't publish that. You can download that yourself by site. We don't put consultant level anywhere in the public domain, but provider level is. Mark, thank you very much. We may come back to you with some questions about the data in a minute. And I know there's some questions that are coming in about remission data. I wonder if we just answer that actually from Andrew. Mark, how did we calculate remission in the data set?
Of 2.6 on the DAS 28, and it was based on the 12 months DAS.
Mark, thank you very much. Paul, can I ask you to switch back on? So that was Andrew. So the DAS score was the definition of and the definition of remission was the standard DAS remission definition.
Sorry, can you hear me?
No. We can hear you, but your webcam hasn't reappeared yet.
Yeah, no, it's strange. Got a slight technical issue here. Let me just see if I can.
You may need to refresh the screen, and don't worry at all if you need to do that. We've got time. I'm just keeping an eye on the questions that are coming through. Sarah, your question I think has been asked by Elizabeth about the impact of COVID, and of course there's a black spot in the COVID dataset because we switched off recruitment to the audit during COVID. I'm aware there's a question as well that's come in about the issue of the outlier status from Elizabeth, and we will come back to that later. I'm not ignoring it. Paul, thank you very much.
Hi. We
have you in clear view.
Good, thank you. Yes.
And we've left the slide up, and I think this is probably the most appropriate slide from the deck to have. But before we start, Paul, I wonder, are you able to just say a few words about yourself and about your background and how you came involved in this? Because I expect a lot of people that haven't met you or don't know you.
Sure, yeah, no. So I was diagnosed with rheumatoid arthritis at the start of 2015. And rather interestingly, it was through Kingston Hospital in Surrey. And I do remember in my very first appointment with a consultant, some data being collected, which I think must have been pilot data for this work. There was a lot going on in that first consultation, as many people are aware. But I do remember that. And lo and behold, here I am 5 years later, having been through the kind of journey of all the trials and tribulations of drugs and whatever, to reach a remission point this year, having finally gone on to a biologic. So I've had a rocky journey to kind of get to remission. But very early on, I volunteered with NRAS to, if I could help out in any way in terms of rheumatoid arthritis advancement. And they put me in touch with this piece of work. And so I joined the chair of the patient panel. I think it's about 2 years ago. You know, so much has happened. And I kind of connected back with that data. So it's a nice kind of circular story in a way. And, you know, it's, you know, I'm quite amazed at how much data is collected. You know, it's actually, from a patient perspective, it's very encouraging. And obviously it's nice to be involved in this piece of work, hopefully to add some value and perspective.
Well, you know my view. I'm yes, undoubtedly, definitely. Can I maybe worth just saying, because you're not alone on the panel, are you? You're part of a team. You lead the team, but
that's right. Yeah. So there's about 8 of us, and depending on state of health and availability, I'd say there's a hardcore of 3 or 4. But people have normal lives. People have babies. People change jobs, even when you've got rheumatoid arthritis. So it's a fluid group, but we're very enthusiastic, and you know, we meet twice a year minimum, but have contact offline as well, and we also obviously cover axial spondylitis as well. So the vice chair represents that side of the equation, which obviously provides useful insight from that perspective. And obviously we plug in through the working group and meet all you good fellows there. So
if I was to come back to the supplementary report and ask if you had sort of a headline perspective and your take on it, what would you have said were the things that really sort of struck you or made an impression on you from the supplementary report?
Yeah, sure. So I think the scale of it is just amazing, really, when you think about it. How you can get a national picture, of a disease which is a fairly low incidence of disease, but to get useful data from a small data set. I'm a marketeer by trade, so I understand the whole world of market research and data response. And this is good levels of response, particularly from patients, who at the end of the day are having a quite traumatic journey for those first 2 years. So to complete questionnaires when you're worried about your job and you're worried about your health and what's going to happen to you. And funny enough, when I look at that slide, this may be unfair, but I tend to think maybe the medical people look to the left-hand side and the patients probably look to the right-hand side, because how's it going to affect my life, and what the impact is going to be on my work, and and my ability to earn money, and the whole mental side of the disease is probably the thing, and I'm not just speaking from myself, but from other patients that lives with them through this. Now, clearly, you want to have low disease and you want to have, low musculoskeletal problems, but it's that other side of the page which is so important to patients, and it's great to have the opportunity to, to add that to the equation, if you like, because in your 15-minute consultation with a consultant, there just isn't time to do everything. So this is another avenue to keep that information live, if you like.
I think that's a really what you say. I think is certainly true for me. When I look at patient-reported outcome data, my eyes are drawn to the health assessment questionnaire because it is reported in trials and it's so familiar to us over many years. What your view, and you've shared this with us over the time from the patient panel, is that questionnaire perhaps has less value to you in terms of its relevance, in terms of what it means.
Yeah, I mean, I think, we, as a patient, you kind of, the medical side of it, and obviously the analysis of the detail of the disease and those issues, obviously we kind of leave to you experts, and it's more a case of how's it affecting my life, what do I need to do, how do I cope? And I think as well, from a patient perspective, seeing similarity across the country, with scores and improvements, with changes, with issues about mental health, with issues around disease activity, is a rich vein. I mean, because you don't know, as a patient in Kingston, I don't know without this kind of data, in a way, am I getting a normalized path? Is it better or worse? It's not necessarily we want to criticize, it's just we want to know, how we can best manage our scenario. And I think in this world where many patients, are happy to get into some of the self-management of the disease, everything that can help in terms of data for that and understanding where you are on the journey, has to be a good thing. So, getting the questionnaire right is important, obviously, and hopefully as patients we can input that into the equation, and I know we have done. But yeah, at the end of the day, I guess our job is as patients is in this research is to humanize it for us, and to make it real, and what can we do, and that's not to take anything away from what the research does, Sorry, I've lost sound, James.
Sorry, that was my fault.
Okay.
There was a motorbike outside. Paul, I was going to say, I may ask you to come back on again in a minute, because I think we may have more questions for you in a minute.
Okay.
Thank you very much. I guess one final thing I would ask of you is, and I don't know if you're happy to share your experience of working with the audit, though. Has it been a positive thing for you? And would you do it again?
Well, definitely. I mean, I think, funny enough, I spoke to NRAS recently and they said, how's it going? And I said, please don't take me off this in terms of, there are other things that I could get involved in, because I think this is so important, I think from a patient perspective as well as from obviously a clinical side. And, I mean, this sounds like I'm, not in any way just trying to justify my role on the thing, but being exposed to all the intelligence that's here, both in the people involved, like yourself, Jo, Mark, everybody else, is incredible, really. It's so nice to know that there is this world trying to look after us. And if I can play a role in helping that, which then helps all of the people coming through on the early stages of diagnosis, because let's face it, that's the most critical part, then this for me is the most important piece of work that I can do in terms of rheumatology. So I've just found it fantastic. The patients I work with and the professionals I work with, it's a great piece of work.
Paul, thank you very much. I will come back to you. I will let you escape for the moment, though. And can I ask Jo to join us? And I think and we will just let the audio switch on.
I've got the sound. Yeah.
So, Jo, this is obviously it's interesting times ahead, but I wonder if, just reflecting on, and there's been some questions in the chat about the disease activity measure, because Mark didn't focus on this, but I wanted to bring it to you. And you obviously, we've captured data on disease outcome, both in terms of patient-reported outcome, but also the DAS and clinical responses. What was your, and do you want to say a few words about the clinical responses over 12 months?
Yes, so first of all, we're managing to capture a fair amount of data at 12 months. Obviously, we lose some at follow-up, but actually our follow-up data capture is good. And I'm not sure we highlighted it, but our patient-reported data capture is particularly good, I think, around the sort of 40% from patients. So I do think the email alerts and the email processing for getting separate data from the patients has been a good development in this phase of the audit, and does seem to be working and does give us a bit more information to play with. I've seen some of the questions about sustained remission, and that is something, unfortunately, we can't specifically comment on from the audit data. What we are getting is a snapshot. And there may be treatments that have been given that are influencing that, but equally, when we talk about people, there's a relatively small percentage, but there are around 20%, I think it was, that have had apparently no impact at 12 months, and that's obviously a group we probably need to look at. And is that a one-off flare at 12 months? We probably need our colleagues to sort of be maybe looking at their individual data in their departments if they've got the time and the energy. And we are encouraging people to use the data as much as possible to help drive quality improvement work, and we're required to do that with our contract with HQIP. We've literally got until tomorrow to submit our latest quality improvement plan. And within that, it's very much looking at how often the data is being downloaded by individual units, and we may need to work with our regional champions to support units to maybe try and look at their data and see, are there things that we specifically need to do or learn in our individual areas. But I think my sort of take-home message is I'm really pleased with the sort of quality of the data and what we're getting. Obviously, this is clinician supplied. We don't have a process for validating that data, so we do rely on people providing their data honestly and reliably. And we hope that people aren't cherry picking who they submit data on, but that is an aspect we need to look at. And one of the things we constantly talk about, and we're required or have been required to look at outliers, particularly outliers in the low performance category. But actually one of the aspects we may need to start looking at is the high performers, and why is that, and what can we learn, and is there something about the data capture, or is there something about what they're doing that the rest of us can all learn from?
The talk of high outliers and the HQIP methodology sort of section is always one that is of great interest. Can I come back on the outlier thing though? Because I guess the very direct question that Elizabeth put is, are we still looking at outliers? Is that still being actively monitored within the audit?
So in terms of notifications of outliers, that's all been suspended. HQIP have asked us not to communicate with our clinical colleagues since we announced that the withdrawal of recruitment of new patients on the 27th of March, I think it was. So in terms of sort of actively looking and updating people, that's not been happening. But we are still required to look at the data, and we will continue to do that. And our plan moving forward, once we relaunch, is to not only historically we've notified people of how they're doing if they are at risk of becoming an outlier, and we look at the data quarterly to give people, if you like, a heads up that they're maybe not doing as well as the national average, and the national average is always the comparator. So for those that are worried that their performance may have dropped off, I'm sure everyone's performance will have dropped off when we go into relaunch of the audit, and it's how we perform compared to the national average is always what we're looking at, and obviously those people who are not potentially performing quite so well will vary over time for all sorts of reasons, and very much our approach is to try and support people in terms of what can we be doing to try and help improve things in that situation. But at the moment we are looking at the data. We've started, as Mark highlighted, looking at the data for the next annual report, and there is no sort of formal notification of the outliers through that process as things stand at the moment. But we will plan to not only identify and give data to people who are at risk of outliers moving forward. Our intention is to write to every audit lead, actually giving them a marker of how they're doing and how they're performing compared to the national average for those key quality statements. So it's quality statement 2 and 3, looking at the old nice quality standards rather than the new ones, just to confuse everybody. But we have stuck with the old nice quality standards in part for continuity purposes. So we've got directly comparable information from year to year.
Can I? There's another linked question, and that is BPT, because that obviously is dependent upon the audit as well. So presumably that's been paused and is coming on hold also.
Yes. So BPT has been withheld. We provide reports once that data collection starts being up and running again. Then that data will be available. But at the moment, the best practice tariff is paused in terms of the data submission.
There's, I'm aware, a comment from someone from Elizabeth. So, which I presume is Lizzie. Hi, Lizzie. The issue of filling in forms electronically and the challenge around BPT, and I think this is something that other units have had. And Jo, I don't know if you want to say anything about that and about the patient-reported outcome measure being a part of the BPT.
So I'm one of the changes that we've initiated, which I think we have notified people of and does seem to be working well, is we're very aware with the COVID pandemic that people are doing many more remote consultations. So we've added a facility to allow people to, or allow patients to submit tender and swollen joint counts to help with sort of DAS calculations, and clinicians can either choose to incorporate that and calculate a DAS or not, but that data, if submitted by your patient, becomes available to you if you look on the clinician site, and you can choose to use that to help calculate a DAS.
Getting the self-reported DAS in there might be one of the sort of bargaining chips to help with remote monitoring of patients. And I'm gonna ask, well, which Jeremy is that? I've got to now have a look and see which Jeremy has asked the question. And it's, Jeremy J. What's the BPT? We've got a question. Lizzie will almost certainly answer that before I've got to it. The best practice tariff. So that is an uplift tariff for people that meet the standards laid out in the nice quality standard. It's worth just over £100 per patient who meets the tariff, and it requires you to enrol someone in the audit and to see them quickly, to start them on treatment quickly, and report at least one patient-reported outcome measure within the audit by 3 months, and a disease activity measure by 3 months. So it's a model, and actually recording patient-reported outcomes in best practice tariffs is advocated by best practice tariff people. And it's not designed that everyone meets the tariff. It's designed as an incentive to work hard, but it's not designed as a way to fund the whole service. Although a service that sees a sizable number of EIA patients in a year, it should in theory be enough to support the administrative costs of delivering the audit. That's the theory. Nothing ever quite delivers what it says. I wonder if I could ask Mark to rejoin us there. And Mark, I was going to ask you a question about specifically the self-reported DAS, because I know you've done some work on it.
Hello. Yes.
You've done a systematic review on this, which I think is in submission. But I don't know if you could say about, is self-reported DAS a valid tool, and have you got any thoughts or any comments on it?
Yeah, so we've just done a review and a meta-analysis of the papers that compare the correlation and agreement between clinician and patient collected tender and swollen joint counts. And what we found is that the correlation and agreements are broadly in line with the inter-rater scores for between clinicians, which is quite reassuring. And it appears that that they perform better with lower joint counts, suggesting that they may have more of a sort of patient-reported disease activity scores may have more of a place in confirming remission in patients that are stable, rather than identifying patients with high disease activity, which is intuitive. I think my experience from doing remote clinics is that it's quite difficult to make biologic decisions in particular, and disease escalation, treatment escalation decisions over the phone or over video call. But confirming someone's in remission is a lot easier. So I think there certainly is a place for self-reported tender and swollen joint counts in collecting self-reported DAS, particularly for those stable patients.
Mark, thank you. And I think that's the way it's embedded in the online PRO system within the audit is designed to not force you to use it, but when the patient has returned the DAS, the patient components of the DAS, they are displayed in the clinician report tool at the point just next to where you would need to enter your own joint count, so you can choose them if you want them. There's one other question, Mark, and I wonder if you might be able to answer this for me, which was about the axial SPA patients. Someone's asked if we are collecting any information on axial SPA in the audit.
Yeah, we have done. So what we've collected in particular is we've been interested in looking at the referral pathway for axial SPA, so where these patients are referred from, and we've collected some information also on initial investigations that have been requested. So we've collected if patients have had an HLA-B27 requested, and if they've had an MRI scan or an X-ray as well. So they're kind of the key things. Is there anything I've missed there, James, for the axial SPA patients?
Who referred them?
Yeah, I said that one.
I want Paul. Would I be able to ask you to rejoin us as well, Paul, at this point? So Paul's co-chair on the patient panel is a representative from NEIAA, from NAS, from the AS side, and we have a strong advocate from the patient aspect to engage with the axial SPA pathway. We don't collect longitudinal data on axial SPA in the national audit for reasons primarily delivered around what the original remit from HQIP that was given to us. I think, Paul, we may have lost you on the video. I don't know if you can turn your video back on. He's maybe guessed I was going to ask him an awkward question. I was going to direct, Leslie's asked a question about what percentage of audit patients are comfortable with computers or smartphones. We don't collect that, and I think that's a very valid question. I'm not sure any of us are very sure about that answer and how it potentially has changed massively with COVID and with the sort of the impact that we've had in terms of the requirement to use smartphones or devices to be able to communicate with your family. There's clearly a very strong link between some of the access to IT services and social deprivation. Mark has done a lot of work looking at the audit data. He had a specific look at social deprivation. I don't know if you want to comment on that, Mark.
Is there
still on mute?
Oh, can you hear me?
Yep.
Great. So looking at the year one NEIAA data, it appears that patients from more deprived backgrounds are less likely to achieve remission at 3 months, as measured by the DAS28, which is an important finding, particularly with the advent of COVID, because as you quite rightly pointed out there, the issue of technology is really important. And as technology becomes more and more crucial to care access, you heard Matt Hancock saying today that he expects the default for primary care appointments to be telephone or video moving forward. And we've gone from 3% of clinicians offering telephone or video consultations to over 95% post-COVID or post the first wave of COVID. So that has the impact to affect the ability of people with lower deprivation with higher deprivation or who are born in more deprived areas with lower access to technology to access services, more so than there already is.
So some listeners, and I wondered if I can ask Jo to rejoin as well at this point, because I'm aware in the last couple of minutes, but some listeners who have been onto the audit website will be aware that we have added to the audit platform, we have added a question, which is how the consultation was conducted within the audit and whether it was face-to-face or telephone or video. And so that is something that in the future, as data starts to reaccumulate, we will be able to look at. Jo, I think we lost Paul in the ether, but thank you very much for rejoining. Paul, Paul, hello. Don't worry, we were going to ask you about smartphones, but Jo, I wonder that there's a few questions that have come up that were sort of fairly early on that I thought we should maybe just come back to. One was about, so Leslie had been picking up on about depression, anxiety, and how, and Paul had obviously picked up on this as being one of the key things that struck a note with him. And I think Mark has responded in the chat that levels of depression and anxiety that we see in the audit, even at 12 months, are above the background population. Would you like to say a few words about why we were asked to collect depression and anxiety in the audit, and any comments on that?
Yeah, so and it was one of the very key things that we were asked to incorporate. There's a big drive on the parity of esteem agenda, and I think there's increasing recognition of the mental health impact. And I think that's no surprise to us as clinicians that we are aware of that. And I think we're also aware of the relative lack of support services for patients. And this is potentially a lever to try and help provide those services to the patients that truly need it. But fairly simple questionnaire is actually giving us quite a lot of information, and certainly I've utilised it as I download information. So when I've looked at my some of my patients that haven't apparently responded at the 3-month and 12-month, it's part of the analysis I look at, and it sort of helps me identify what I need to be doing to try and support my patients. But there is a sort of wider agenda, if you like, of dealing with the sort of mental health issues that go alongside particularly chronic conditions, but any condition. It's a big agenda item within the NHS at this stage, and it was a condition of the contract that we were looking at that.
One thing to potentially finish on, Jo, is obviously we do capture information on access to mental health services, to psychology support through the organisational form. We normally collect that information in May, and we open the form for 3 months. That hasn't happened this year for obvious reasons. Will we be collecting organisational data for 2020, 2021, and when will that happen?
We will. So we're waiting for clearance from HQIP and NHS England as to when we can mandatory data collection for the audit. Hopefully people have seen that they've had emails, I think today, highlighting that from Monday you're able to start uploading data, but it's not mandatory. So if you're seeing new patients and want to, if I say, try and get back into the routine of the audit, and I appreciate there are many that may find that a huge obstacle, but we're trying to encourage people to get back into that sort of routine without it yet being mandatory, and we've been given the clearance to do that. We hope that relaunch of mandatory data collection will be later this year, and we think it's likely to be September, October time, and we anticipate collecting the organisational data information around that time, and we'll leave that data capture window open for approximately 3 months, so that we've got plenty of time for people to update their information. And we're really interested to look and see if there have been any sort of changes in staffing. I'm aware that GERFT and others are looking at the sort of impact on staffing and activities that units have been doing linked with the COVID pandemic. And we're very keen to try and sort of link that information to help us understand what are going to be the challenges for some units, maybe more than others, et cetera, et cetera. So we're very conscious of the different stresses on different units, and how different units have had different requirements in terms of helping out on the acute wards, and that all needs to be sort of thought about. And we appreciate people still, my department still hasn't got its full staffing back. We still got our staff on the medical wards. So getting back to normal rheumatology activity is going to be a while off for my department, and I'm sure the same for many.
I think, yeah, we even lost our clinic space. It's strange times.
Yeah.
We should draw this to a close. We've had 2 questions we haven't answered, and Peter has just commented on the socioeconomic. There's nothing novel about the association between social deprivation and outcomes in healthcare. And yes, we have looked. Mark has done this work, and that paper will be. It is in submission at the moment. Is that right, Mark? Took a step back today, I think. and Brahim, est-ce que nous avons ajusté les recommandations COVID-19 par rapport au traitement institué? Yes, I think Lizzie McPhee will respond to that in French. But there are BSR recommendations. There is a huge amount of work going on around COVID-19 and treatments, which is a topic for an entirely different webinar. And I wonder whether at this point we can draw this to a close. Can I finish by doing 2 things? First of all, to send an enormous thank you to everyone who's presented this evening, to everyone who fills data in for the national audit, to Jo, who leads the audit and steers us in a sensible direction. And also, in parallel to that, also a thank you to Paul, who's joined us today. Paul's work behind the scenes. I'm sorry you're not on video at the moment, Paul, and we lost you temporarily, but the work of yourself and the patient group is enormously valuable. And then finally, there is a membership survey happening on the 15th, which is open live now and is live until the 15th of August. And Stephanie may add the link in the chat, possibly. But please do complete the BSR membership survey if you haven't done so already. Jo, would you, any final comments or anything I've missed?
On at least the supplementary report, and if you haven't had a chance to read it, please do. And if you haven't had a chance to download your own data or don't know how to, please contact the audit team or your regional champions to be able to do that. I appreciate there are huge pressures on everyone's time at the moment, but this audit was gaining good momentum before COVID broke through. We are keen to try and get this up and running again, to just maintain information gathering on the challenges that units are facing, and see if what we can do in the way of securing support to improve the quality of services where that's needed, and see what we can learn from people who are doing well, are the sort of key messages. And my thanks to everyone who has been engaged with the audit, and I hope you feel you have the energy after everything that's been happening over recent months to re-engage with it once we get that back up and running, and hopefully get a bit nearer normal in terms of what our mainstream rheumatology services are about.
I think we couldn't agree more with that, Jo. I hope that although sometimes the audit feels like a punishment, I hope that actually it is an opportunity, and potentially it's going to be a strong lever for justifying switching back on our services if we can start to look at variation in switching back on across the country. Okay, well, it is time to have a respite from work. Thank you very much, everyone, for joining. Bonsoir to Brahim, and good night to everyone. All right.
Very much, James, for hosting that. Thank you, Mark, Jo, and Paul, and thank you to everyone for joining us. I hope you have a lovely evening, and it is the end of the session. Thank you.